Assalamu alaikum everyone. So we'll be starting the lymphoma session and I'll be the moderator for this session. I'm Dr. Shafaq and we have some distinguished panel of experts with us today. So this session chaired by Dr. Ayaz Mir, Professor, Head of Hematology Department, Shifa International Hospital. Then we have Dr. Amjad Zafar, Consultant Medical Oncologist, Hameed Latif Hospital. Dr. Sairah Ahmed, Associate Professor and Director of CAR-T Program at MD Anderson Cancer Center. Dr. Salman Fazal, Director Cell Transplantation Program, Allegheny Health Network. Dr. Shahzad Nasir, Consultant Hematologist, Quaid-e-Azam International Hospital. Dr. Usman Ahmed, Consultant Hematologist, Shaukat Khana Memorial Cancer and Research Hospital. So I would request the panelists to please join us on stage. And the speaker for today's session is Dr. Stephen Ansell. Dr. Stephen Ansell has substantial contribution in the field of lymphoma, and his research has contributed to the use of immune checkpoint therapy in lymphoma, and he will be discussing how I sequence therapy in Hodgkin lymphoma.
Well, thank you very much for an opportunity to participate in your meeting. Really grateful for the opportunity, and the goal for me today is to talk about how I sequence treatment for Hodgkin lymphoma patients in 2024. And as you know, a lot has been happening and changing, and so I hope to show you how we got to the place we're at right now, and then discuss with you how I would typically use various treatment combinations for patients as you go through the course of the disease. I need to start by just saying that my institution does receive funding for clinical trials from the companies listed on this slide, and a number of them are pertinent to the conversation that we're about to have. So as we start, I just think it's important to kind of center ourselves again on biology and reminding you that Hodgkin lymphoma is very different to other kinds of lymphoma in that the malignant cell is really in the minority. And you can see in the top left here, two arrows pointing to Reed-Sternberg cells, and those cells are really within a large environment of other immune cells. And on the top right, you can see a closer view of the owl-eyed cells, and you can see the other immune cells all around. What I'm showing you in the two bottom slides are really what are going to be the focus of our conversation today. On the left, on the bottom, you can see CD30 staining, highlighting the Reed-Sternberg cells. And obviously, as you know, brentuximab vedotin targets CD30 and delivers the MMAE toxin to those cells. And on the bottom right, you can see the expression of PD-L1 and PD-L2, and that's due to copy number gain and amplification of chromosome 9p24.1, as you can see on the top of those panels, and you can see the increased staining at the bottom on the Reed-Sternberg cells, and that's the target of pembrolizumab and nivolumab and other PD-1 blocking antibodies. So we're going to talk a lot about brentuximab vedotin and PD-1 blocking antibodies in combination with standard therapies and how all of that fits together in the management of patients with Hodgkin lymphoma. Just a minute to talk about stage of the disease, because as you well know, Hodgkin lymphoma treatment is still very much driven by the stage of the disease. So I'm highlighting here on the left, you can see the PET scan of a patient with a limited stage disease. And you can see the FDG uptake in multiple lymph nodes in the chest, and you can see a variety of prognostic factors in the table on the right. And the reason that's important is that we take Hodgkin lymphoma with limited stage disease, and those patients, we differentiate them based on these risk factors into favorable disease and unfavorable disease. And that really influences how much treatment the patient does receive. Here is a patient with advanced stage disease, and you can see again extensive FDG uptake on the PET scan on the left side, and you can see what is called the Hassan-Cleaver index with a variety of different prognostic factors. And the reason I highlight this is that while PET scanning and others have become almost more prognostic than this particular kind of index, the index is still used to identify really high-risk patients who may require a more intensive therapy, and we'll touch on that in just a minute. So if you were to take a landscape view of kind of what has been standard therapy, and I'm just highlighting this because then I'm going to talk about how the new therapies are impacting this paradigm of treatment, you can see early stage patients with favorable prognostic factors. This really is very limited disease. these patients often would have sufficient treatment if they receive 2 cycles of ABVD chemotherapy and very modest 20 centigrade of involved field radiation treatment. If the patient instead had unfavorable characteristics by the prognostic factors I just showed you, but still early stage, they would need more chemotherapy, 4 cycles of ABVD chemotherapy, and more radiation therapy, 30 gray of involved field. I will touch on in a minute about ways in which we're trying to minimize radiation and other toxic therapies, and sometimes based on the interim PET scan being negative, the radiation can be omitted and just 3 cycles of chemotherapy can be given. In contrast, patients who have advanced stage disease, combination chemotherapy is really the standard, and I will talk in a minute about nivolumab AVD chemotherapy, brentuximab AVD chemotherapy, using AVD chemotherapy, leaving out the bleomycin, or intensifying the treatment, utilizing, in the past we used escalated BIACOP, but I'll show you some recent data showing that BRIA-CAD is really the therapy of choice in advanced stage patients. So taking us back now to ABVD chemotherapy, I showed you a minute ago that in limited stage patients that we could typically regard 2 to 4 cycles of treatment with involved field radiation therapy as the standard. But the RAPID trial now about 8 years ago really looked into whether or not radiation therapy could be omitted. So in this study, patients received ABVD chemotherapy for 3 cycles, and then they were, based on their PET scan, if PET scan negative, randomized between stopping treatment or receiving radiation therapy. Important to note, this was officially a negative study because, as you can see, there was an advantage to giving radiation therapy. But because of the very modest difference between the two, actually there were a lot of folks that felt that that decrease in progression-free survival was probably worth omitting the radiation toxicities. And so many, including our institution, actually then adopted that as a treatment paradigm. I will say that we went back 10 years later to see how we were doing and looked at using combined modality therapy that you can see in the blue line at the top versus chemotherapy alone per the RAPID trial, and you can see our outcomes were a lot worse. And we found that in this real-world setting, often one becomes a little more relaxed about the criteria. Patients were more likely to be a bit more bulky in their disease. Patients would not have, in that case, have been on this clinical trial. And you can see that the results, therefore, did not mirror the RAPID trial and actually were worse. So in our practice, we've been a lot more cautious about omitting radiation therapy, particularly when patients have more bulky disease. Now, the next thing to say is, well, instead of radiation and instead of just omitting it entirely, could you replace it with the radiation with one of the drugs that we spoke about, either a PD-1 blocking antibody or the brentuximab vedotin targeting CD30? And here is a trial, a randomized phase 2 study from the German Hodgkin lymphoma study group, looking at either using sequential or concomitant use of nivolumab plus AVD chemotherapy, omitting bleomycin. And you can see here that the outcomes in this study are outstanding. Now, we'll notice that this did not officially leave out the radiation because most patients still receive involved field radiation therapy at 30 gray. But you can see here that the patients had a phenomenal outcome with a progression-free survival that is remarkably good. Now, there have been a number of other studies that have actually looked at, again, stratifying people by PET negative and PET positive, but specifically omitting radiation therapy. Here you can see in this trial, brentuximab AVD chemotherapy was given for 3 cycles. Those that are PET negative, instead of receiving radiation, received 8 doses of nivolumab consolidation. Those that were PET positive received the combination of brentuximab vedotin and nivolumab for 4 cycles. The important thing to take away here is that the majority of patients had a negative PET scan at the interim point, and after consolidation treatment, 100% of patients remained progression-free. Now, clearly, we're still going to need a randomized study to prove that this strategy is as good or better than radiation therapy consolidation, but certainly these results look very promising. Now, this is a case to say, well, if brentuximab and nivolumab, new therapies that are very effective, How about we use both of them together, then with some of the chemotherapy, and in this case, just the doxorubicin and dacarbazine. And this was presented at ASH last year, and you can see that in this study, pretty small group of, or pretty sizable group, sorry, of patients, about 150, but you can see the overall response rate here was 95%, 90% of whom achieved a complete remission, suggesting that this may be a very effective therapy and potentially an alternative in the future. Now we're going to just change gears and go from limited stage patients, which I just showed you, to advanced stage patients. I beg pardon, to advanced stage patients. And in this case, wanting to talk about how we may minimize toxicity. And this is the results of the RATHL trial. So in the RATHL trial, the goal here was to, in patients that are benefiting, omit bleomycin. And you can see here that the study looked at, if you're in a PET negative situation after 2 cycles of treatment, you either continued with ABVD chemotherapy or bleomycin was omitted and you received just AVD chemotherapy. I think the important thing to note here is that patients had a good outcome, about 80% of whom remained in remission, and you could safely drop the bleomycin without a decrement in the outcome of patients. Notably, if you only gave 2 rounds of chemotherapy, including bleomycin, very few patients actually received or developed any bleomycin lung toxicity. So that really allows us to consider in low-risk patients this as a strategy, omitting bleomycin, recognizing that that has a low risk of bleomycin lung toxicity. Well, the new drugs have been applied in the advanced stage as well, and the results have been quite promising. So first of all, brentuximab vedotin was added to AVD chemotherapy and compared in a randomized fashion to the ABVD regimen for stage 3 and 4 disease. And you can see here the green line at the top is the brentuximab AVD arm, and the outcome was improved as far as progression-free survival, but it's also, as shown on the right-hand side, for overall survival. So this was the first time in 30 years that we really saw an overall survival advantage for a change in a frontline regimen. However, the same was also seen with the use of Briacad. So Briacad is a modified BIACOP, utilizing brentuximab vedotin and adjusting the doses of some of the other drugs to minimize side effects. This was just recently published. It was a comparison of Briacad to escalated BIACOP, and 2 important lessons came from this. Briacad was substantially less toxic and better tolerated with fewer complications, and the progression-free survival estimates were actually superior for Briacad over escalated BIACOP. And I think that really has made Briacad the standard of care for advanced stage patients with high-risk features that you would have considered escalated BIACOP in the past. Most recently, and this has just been accepted for publication, I understand, is the combination of nivolumab, the PD-1 blocking antibody, and plus AVD chemotherapy to brentuximab plus AVD chemotherapy. And you can see in this head-to-head comparison that nivolumab AVD chemotherapy at the 1-year mark had a better progression-free survival than the brentuximab AVD chemotherapy. And subsequent presentation at 2 years shows that these data are holding up. The other thing that was very interesting is that this was a particularly useful regimen in elderly patients. So patients over the age of 60, many of whom do not get onto the more intensive trials. There was a sizable percentage of them in this comparative study, and when they were analyzed, you can see that receiving nivolumab AVD chemotherapy when you are an elderly patient was far better tolerated with better outcomes than receiving brentuximab plus AVD chemotherapy. So if we take frontline therapy, and I'm noting here this is my choice, when asked how would I treat these patients, I think if you have early stage with favorable characteristics, modest amounts of low burden disease, those patients are best served by 2 cycles of ABVD chemotherapy and 20 ray of involved field radiation treatment. I think in contrast, if you have a larger amount of disease, but you're not bulky, particularly female, where you want to avoid radiation that could impact the breast tissue, particularly a low burden of disease, there may still be room for utilizing this rapid approach for an interim PET negative patient. I will say that that's a space where there's going to be comparisons to using novel agents instead of radiation treatment. If you have more disease, more extensive disease, I still favor using 4 cycles of chemotherapy and 30 gray. And in the advanced stage setting, if you have low-risk disease, particularly if you're older, I think nivolumab AVD chemotherapy, if available in your country, is certainly the way of the future, well tolerated with good outcomes. In contrast, if you have high-risk disease and need an intensive approach, the data would support the use of BRIACAT. So I'm going to change gears now, and for the last few minutes, talk about relapsed Hodgkin lymphoma. And again, I want to stress that I very favor clinical trials, so this is outside of a clinical trial. And I think as we're going through, I want to talk about a few things. What's the preferred salvage regimen when you have novel therapies that are typically being given in frontline? Should salvage treatment contain PD-1 blocking antibodies? And we'll talk about that. What's the consolidation post-transplant? And should you use an agent in consolidation if it's been used before the patient actually came to a transplant? So firstly, just to say, regimens now that are building on standard treatments by adding PD-1 blocking antibodies or brentuximab vedotin are really highly effective. This is GVD chemotherapy with the addition of pembrolizumab, a small study, but I think the important thing here was to say the response rates were very high, 100%, 95% CR rates, and all patients being able to proceed on to an autologous transplant. Those kinds of response rates are way higher than what we would typically expect just with GVD chemotherapy. This is treatment with ICE chemotherapy with nivolumab added, and similarly, high overall response rate of 81%, CR rate of 71%. And again, by the time, that was just with the nivolumab part, by the time all treatment was completed, you can see the response rates were in the 90%, and most patients able to go on to a transplant. Again, suggesting that using PD-1 antibodies with chemotherapy is very effective in the salvage setting. Just focusing now on brentuximab, this is with bendamustine. You can see again a response rate that's in the 93% range, again with very high percentage of patients able to proceed to an autologous transplant, preferably in CR, giving them the best likelihood of outcome. And this is if you took brentuximab and nivolumab together and just used that as the salvage treatment. And you can see again here that the overall response rate was 82%, 61% of the patients had a complete response, suggesting that even without a true chemo approach, but rather a novel agent approach, the response rates are very high. This is important data that's real world data looking at bringing these new agents into the current setting. And the blue line at the top are the patients that received PD-1 blocking antibodies before proceeding to a transplant. So everyone went to a transplant, but you can see those that received PD-1 blockade as part of their regimens before transplant had the best outcome. And I think that's an important message, that we seem to see that PD-1 blockade improves the outcomes post-transplant. Now, what about what should you be doing post-transplant? And again, the standard was brentuximab vedotin as consolidation after a transplant for high-risk patients, either those refractory to treatment, early relapses, or relapsing outside of the nodal system. And the use of brentuximab vedotin was really the standard treatment in these patients. This is a little complicated now, particularly because many people are receiving brentuximab vedotin in frontline, but important that if they have not, this is data that you should consider. This is data really to highlight the fact that PD-1 blocking antibodies have been tested in the same space. Now, I have to stress, this was not a randomized study as the Athera trial was, and this is a far smaller study, but this did meet its criteria, showing that patients receiving pembrolizumab post-transplant as consolidation had a progression-free survival of 82%, which was better than what was expected. And the overall survival at 18 months was 100%. So this just would suggest that this is another space where we will need to look for a randomized trial to show that PD-1 blockade could be used in a similar fashion to where brentuximab vedotin has been used. Finally, just to say a few words about other therapies if people fail post-transplant. Won't spend a lot of time here, but this is to highlight that CD30-directed CAR T cells have shown efficacy. The durability of the response is still a little challenging, but I think the importance of, obviously, is that this is a therapy that can be developed and could be effective. This is utilizing new immune checkpoints. So this was an anti-LAG3 antibody called Favelismab in combination with a PD-1 blocking antibody. But note, all of these patients had failed PD-1 blockade. And you can see that the response rate here was about a 30%, but many people benefited based on the waterfall plot. So more than one checkpoint may be a new strategy for the future. And this is to utilize NK cells that are obtained from cord blood, and then a bispecific antibody is being used to pre-treat these cells. AFM13 binds to CD16 and CD30, so it binds to an NK cell or a monocyte and then to the tumor cell. Again, we have to look to see whether these results are going to be durable, but the response rates were very high. So as I end here, what is my choice of therapy when patients relapse outside of a clinical trial? Personally, I would use chemotherapy. I use ICE chemotherapy, but GVD would be very legitimate. But I would add a PD-1 antibody if the patient has not received that prior to then going to a transplant. I think that salvage regimens across the board should include a PD-1 blocking antibody based on the fact that real-world data shows that these patients do better. If the patient hasn't received brentuximab vedotin before the transplant, I would still favor in high-risk patients adding brentuximab vedotin as consolidation. However, if the person has had a PD-1 blocking antibody or has had a brentuximab vedotin, I would not use those agents again. So as we end, here are a few takeaways that I think for Hodgkin lymphoma should be considered. I think new agents such as brentuximab vedotin and PD-1 blocking antibodies are now standardly being included into frontline treatment, and I think that should be considered. If not used there, at salvage, I think a PD-1 antibody, if available, should be added into those combinations. And then clearly we're going to need additional clinical trials to test what to do for patients who fail all of that, because we're going to need better and more effective therapies. So with that, I'll end, and thank you very much for your time and attention.
So we have Dr. Sairah with us. And
okay. So I can start a question with Dr. Sairah, if that is okay?
Yes, sure.
So Dr. Sairah, it's Usman here. My question is that if you've got a young fit patient, but they have got cardiac issues or low ejection fraction on echocardiogram, how you treat the Hodgkin's lymphoma?
This is an infrequent situation for young patients, but it's actually something that we often see with older patients. And I think, there's kind of two different ways to be able to address the situation. The first is really having them optimized by a cardiologist to see if there is a potential modifiable or reversible risk factor. So if it's ischemia that's causing cardiomyopathy, et cetera, can they potentially improve that? What we have done with patients who have borderline ejection fractions is to do infusional doxorubicin. So give the doxorubicin over 24 hours, or potentially use a cardioprotective agent like dexamethasone. But for those patients that just cannot tolerate any anthracycline, there are some anthracycline-free regimens. The outcomes are not as good. The curative intent kind of is decreased and their prognosis is worsened. So particularly for those patients where the kind of intent is curative, we still would like to keep the anthracycline. Now, you could potentially dose reduce after you get to a complete response. So after 2 cycles, you may be able to kind of cut down on the dose and still keep some of the anthracycline. This would be a situation where I would advocate for a novel agent included in the combination, such as a checkpoint inhibitor or brentuximab, because you're going to have better outcomes with those combinations in comparison to older regimens.
So any other questions from our panelists? We have Dr. Salman Fazal with us online as well.
So while waiting for the question from the audience, I'll ask a question from Dr. Salman. Dr. Salman, what's your view in the use of maintenance brentuximab post-transplant in Hodgkin's lymphoma, autograft?
So, as Dr. Ansell also presented, if they have not used the brentuximab up front, then clearly there is an advantage of using that in those patients. So that's pretty much depends upon what agents they have used it up front. As their novel agents are being used up front, that's where the benefit becomes like whether or not there is still advantage or not. But clearly, if somebody has not used it, there is advantage in my opinion.
So I think we have come to an end of the session, and I would like to thank the speaker, Dr. Stephen. Thank you so very much for your nice talk. All the panelists and all the participants who have contributed to this session. Thank you.